Hi, my name is Joseph Duraney, and I am the Director of Pediatric and Congenital Heart Surgery at the Mayo Clinic in Rochester, and I'm joined by my colleague, Dr. Elizabeth Stevens.
And we're here to discuss what's going on now and where we're going in congenital cardiac surgery.
So in the current healthcare paradigm, we look at the current practice of medicine to be more reactive than we would like, mostly symptom-based. We'd like to think that the treatment that we offer is corrective. Many of the procedures tend to be invasive. Some are viewed as being heroic. Oftentimes we are intervening too late in the game. Healthcare is expensive across the board. And in some cases it's become depersonalized. It's oftentimes too slow for both the patient and the practitioners. We oftentimes make it more complicated than it needs to be. It can be inconvenient, either with regard to location or time of the day, and we tend to do it in person. But in the next 10 years, by the time we get to 2030, we believe things will be a little bit different. And with regard to congenital cardiac care, we think that it'll be more preemptive. Now it is the norm that many women are getting prenatal ultrasounds, so we know in advance of what we may be dealing with that allows us to prepare. There will be more genetically based tests, blood tests, that might help us understand what some of the anomalies are. I think some of the operations, as technology advances, may become progressively more curative. Operations are being done with smaller incisions, and in some patients, even robotic-assisted technology. Most care now is routine. The ability to intervene at an early stage is really at the center core of congenital heart disease, and we've learned over the last 30 years that the earlier we intervene, the better the outcomes. We do need to make a concerted effort to make things more affordable. And it's always been personalized in the pediatric arena, and it generally tends to be fast. And we try to make it more uncomplicated, and it is convenient or inconvenient, depending upon the viewpoint of the practitioners or the families. And while we would like to think that it could be accessible anywhere, there will be some unusual situations where it will be important for patients and families to seek out very expert care for the unusual operations where not everybody might be comfortable.
Well, you touched on the fetal diagnosis, and I think the neonatal group in particular, we've made great strides with. And one of those is being able to diagnose them during pregnancy and being prepared to do interventions even the day that they're born. So that's really made great improvements in our care. I think one of the other things regarding the neonate and infant groups is we've learned more about neonatal physiology and understand better how to protect their brain during surgery, how to monitor them. So we've changed our bypass strategies, providing blood flow to the brain, things like that that we haven't been doing in previous decades. And then increasingly, as in other areas of cardiac surgery, we have interventional catheter-based technology, so things like PDA stents or ductal stenting instead of a surgical shunt, which can be very instrumental for some of our babies.
Yeah, I think you really have brought on a lot of good points. So I think what I'm hearing is that we've really sort of gotten close to perfect with neonatal heart surgery. We're doing it earlier and earlier. The technology is sort of in some ways moving to catheter-based therapy, and that brings up the whole subject of fetal heart surgery. Right. And while fetal heart surgery has really been applicable to a very, very narrow spectrum of problems, I think the technology and the experience of the staff is getting better and better, such that now we have multidisciplinary teams that can focus on fetal cardiac interventions, which is even earlier surgery, right, even before they're born. And although it may not be the most definitive intervention, it may be a step to either lessen the severity of it after they're born or make the complexity of the surgery that needs to be done simpler. So it's all a step in the right direction.
Yeah, I see that more in the future, being able to use fetal interventions, as you said, to improve the prognosis of certain subset of patients. As far as those infants and children, one of the things that Mayo's been very involved in is understanding valve disease and intervening on valves, being able to repair them as opposed to replacing them. So that's some of the technology, and then also be able to assist certain hearts with devices as those devices get smaller and smaller.
Yeah, that's right. And I think you've also alluded to, the older age. And I think as we sort of move through the spectrum now, the results with surgery in infants and children has gotten to be so good that there's an expectation that they'll live until the adult
Right.
years. And, with that comes either the initial operation aspects of it wear out, valves that may have been repaired need further intervention, sometimes replacement. And this brings up the subject of imaging, which we have wonderful access to now, and the ability for the surgeons in particular to prepare for what they may encounter is really just truly remarkable. And if we think about other aspects of technology that is applicable, we have minimally invasive and robotic techniques which are not currently available in infants and small children, but it is available in teenagers and adults. And it's not always appropriate for some lesions, but when it is applicable, it's a wonderful application because the length of time in the hospital is less, the recovery time is less, and so it's really amazing. And then, the other side of this is the reoperations, and the reoperations can get to be quite complicated, particularly when you've accumulated a fair number of them. And these models really give us the ability to both study the anatomy and really understand what's going on. And of course it's life size to a specific patient, so you can see the three-dimensional relationships to the chest wall and so on. But the other wonderful thing about it is that the model can be reproduced in a soft model. So if there are concerns or reservations or anxiety with the surgeon because it's something that's rare, you do have the ability to actually almost perform the operation in your office yourself, which really I think is also quite...
This is a great example that was used for surgical planning. And then we have another one this was a 2-year-old with planning an unusual type of a vascular ring, and so we can know exactly where we need to go to do the anastomosis, and again, life size, so we were able to plan ahead of time for operative repair. One of the most dramatic changes over the last decade or so is the amount of data that we have relative to monitoring or all sorts of testing, and how that's only going to increase going forward. So that's a huge new field that we're getting involved in.
Yeah, I think that's exactly right. So the STS database has been a wonderful repository of data collection in all of cardiac and thoracic surgery, but it's been really particularly helpful in congenital because of the spectrum of operations and the lower number of operations across the whole landscape of the procedures that we offer. And so we've learned a lot over the last 25 to 30 years. And moving forward, we now have the ability to apply artificial intelligence. And artificial intelligence requires large amounts of data that have been validated, which we currently have now. And so the ability to sort of make a transition from evidence-based medicine, which is what we currently do, to intelligence-based medicine is really an opportunity for us to get closer to making what we do better and better and better, and closer to perfect, perfect, perfect. So the other thing that artificial intelligence offers, not just congenital cardiac surgeons, but all surgeons, is the virtual reality. And of course, the models that we've just talked about are kind of the first version of this, but we do have the ability now in some circumstances to recreate this in a virtual reality session, which is probably one of the most powerful educational tools. The models, though, I do think are helpful because it gets us to exactly what we're going to be doing in the operating room. So the combination of both will be great moving forward, and that next decade, I think, will be marked by further improvements.
So to summarize, over the next decade in congenital cardiac surgery, we have the opportunity to refine and introduce many aspects of care. So for instance, the prenatal diagnosis with ultrasounds, as well as genetic testing, is being refined, and we're introducing fetal cardiac surgery, which can make a huge difference in a certain population. And as we get better, these patients live longer, and we have opportunities to refine things like minimally invasive approaches and robotic approaches for the adult congenital heart disease patients, many of whom are coming back for reoperations. Another component is refining protocols for our patients so that we have better affordability, shorter length of stay, returning to work or school earlier, and then of course imaging, which we've touched on earlier.
Yeah, exactly. The imaging really provides enormous opportunities for improvement. We've talked about the application of imaging and the development of models to either help you study and prepare or to actually perform the procedure in advance. And virtual reality adds another element of education and preparation, in addition to the roles of artificial intelligence and the understanding of big data. All of this technology and all of these strategies will help us get closer and closer to perfection in congenital heart surgery and outcomes over the next decade.